Hello there, my name is Han Zhang. I'm a gastroenterologist and I'm here to discuss with you the basics of management of GERD. Acid reflux is so common, it occurs in almost 20% of the adult population in the United States. The typical symptoms of acid reflux are heartburn or acid regurgitation. And patients with this will say sometimes that after eating a large meal, they'll lay down and have a lot of reflux. These are the typical GERD symptoms and usually patients will undergo treatment. However, there are other atypical symptoms of GERD that are more complicated when it comes to treatment. And these are patients with symptoms such as chronic cough, globus, laryngeal symptoms, hoarseness, non-cardiac chest pain, among others. And what makes it difficult is that a lot of patients with these symptoms don't have GERD as the sole cause of their symptoms. And usually the guidelines recommend upfront objective pH testing prior to undergoing extensive therapy for GERD. Now it's important to know, how does acid reflux come about? So if you think about it, the stomach is used to making acid and it sees a lot of acid, but the esophagus is not used to seeing as much acid. In between the esophagus and the stomach, there is a lower esophageal sphincter, which usually stays closed to prevent refluxate from coming up into the chest. Now, it doesn't always stay closed. Sometimes it has to open to vent air, and that is what we call a transient lower esophageal sphincter relaxation. And sometimes when it relaxes, it can bring up not only gas, but a little bit of acid with it, and the patients can feel heartburn. The other thing to note is that the chest is under negative pressure in relation to the abdomen and the stomach, which is more positive pressure compared to the chest. So if you go back to high school physics, you'll know that things go from positive to negative pressure. So what prevents that acid from going from the stomach, higher pressure, into the lower pressure, into the chest? Well, that is called the anti-reflux barrier, and there are many components of this. One of the components is the lower esophageal sphincter, which can stay closed. The other component is the diaphragmatic crura, the diaphragm. They both act at the same place to close off the lower esophageal sphincter. And sometimes if a patient has something like a hiatal hernia, then the stomach slides above the diaphragm, so the lower esophageal sphincter is above and the diaphragm pinch is below, so they're no longer acting together, but now they're separate, and there's less of an ability to prevent acid from coming up. In addition to hiatal hernias, there's other things like if a patient has gained a lot of weight, that puts a lot of pressure in the abdomen and can push the acid up. If a patient is on GLP-1s, for example, they have delayed gastric emptying, that can worsen things as well. So it's important to know the physiology behind it. Now, management of GERD always starts with lifestyle modifications. You know, things like weight loss through healthy dieting and exercise, not eating within 3 hours of bedtime, because if a patient eats, they lay down right away, then all that acid will want to come up. Using blocks underneath the bedpost, head of the bedpost, to elevate the whole bed. Note that a lot of patients will say I use pillows, but a lot of patients will roll off the pillows in the middle of the night. So I think it is better for them to actually elevate the entire bed, 6 to 8 inches usually. And then, of course, adjusting the type of food that they're eating. Now, if lifestyle modification is not working, then you would progress to medication options. If a patient only has intermittent symptoms, like maybe 1 or 2 times a week, only if they eat a certain meal, then maybe it makes sense for them to take a medication that is as needed. There are many options, one of which could be an H2 blocker such as Pepcid. I personally really like Pepcid Complete, which seems to work very well. Do note that if a patient takes a medication like famotidine or Pepcid consistently, they may experience what's called tachyphylaxis, where the medication starts to lose its effect over time. One of the mainstays of therapy for patients who have consistent symptoms of acid reflux are PPIs, or proton pump inhibitors. It's important to know that PPIs must be taken around 30 minutes before the meal and not during or after the meal. Not all PPIs are the same. For example, pantoprazole happens to be the weakest PPI and rabeprazole happens to be the strongest PPI. The other part to note is that patients frequently ask, what is the safety of PPIs? The patients go online and read a lot of different information. It can be quite confusing. So for this, I highly recommend you check out a well-done randomized controlled trial that randomized patients to PPI versus placebo for 3 years. Very well done study, which essentially found that there is only a statistically significant difference in the rate of digestive tract infections. Most of the other fears did not turn out to have a statistically significant difference between the two groups. So this is a study which I'll put the link below. I highly recommend you read that study so that you can counsel your patients. And this is a question that you will get all the time. There are some medications that we don't have time to go into detail during this video, some of which include vonoprazan, which is a potassium competitive acid blocker. That medication doesn't have a strict timeline. You can take it at any time, and that may help your patients who struggle to take PPIs at a consistent timing. Alginates are another option for adjunctive therapy. Now let's say if a patient has really bad heartburn symptoms. They are taking a PPI, taken properly at a higher dose, but they still have symptoms. Now if this is related to acid reflux, this will be rare, but it can happen, and this is where further testing such as endoscopy or objective pH testing could be helpful. The reason for that is there are three common scenarios here. One, the patient has very severe GERD, and despite maximum PPI therapy, they still have residual acid reflux. This will be rare, but maybe a patient has developed a large hiatal hernia, maybe a patient gained a lot of weight, maybe they were put on a GLP-1 and now they have delayed gastric emptying. If you do an endoscopy on these patients, you may see something like persistent erosive esophagitis. That may prove their presence of active acid reflux. This is one possibility. A second possibility is that the patient may have reflux, but instead of pathologic levels of acid reflux, they either have a normal amount of acid coming up in their esophagus, or they have reflux of liquid that is non-acidic. And this can happen if the acid is already well controlled, but they still have liquid coming up into the esophagus. And a lot of times patients won't even feel that. They won't even know that they have it. But if a patient does feel it and they have the symptom association with those reflux episodes, then this is something called reflux hypersensitivity. The third possibility is that the patients have no reflux at all, but they actually feel the heartburn still. And this is something called functional heartburn, and that is called a disorder of gut-brain interaction. Now, in these cases where patients have heartburn, they take a PPI, but they still have refractory heartburn symptoms, it's very tempting to automatically think that the PPI is not strong enough. However, if you look at the data, it actually says different. If you look at this well-done study published in the New England Journal about patients who have heartburn symptoms that were refractory to PPI, the pre-enrollment workup was very, very interesting. So the thought is that maybe all patients who have heartburn, who are on PPI, but still have heartburn symptoms, are likely to not have taken strong enough PPIs. But this study showed that in those patients, 17% of those patients, their symptoms resolve with a proper PPI trial. So just by taking it properly under the supervision of a different physician, their symptoms resolved after PPI. 10% of them actually had motility or other non-GERD disorders. And then what's surprising is that a whopping 41% of those patients turned out to have functional heartburn, meaning that they have no acid regurgitation, no reflux, but that they felt heartburn despite that. 15% had reflux hypersensitivity, and lastly, only 17% of them had true refractory pathologic acid reflux. Only 17% of this group had acid reflux that were not controlled with PPIs. Again, based on this data, it's important to know that most patients who have heartburn, who are on a PPI but don't get better, most of those patients actually don't have residual acid reflux. Most of these patients probably have a concurrent component of a functional disorder that is making their symptoms difficult to treat. And this is extremely important to understand for treating patients with GERD symptoms. So now this is the new model of GERD and reflux symptoms, is that they are a spectrum between true acid exposure and hypersensitivity and functional disease. In order to distinguish between all of these disorders, this is where the role of objective pH testing comes into play. If a patient has refractory heartburn symptoms and are not getting better on a PPI, then usually you may consider sending them for a transnasal pH impedance testing done on maximal PPI suppression to see whether or not there is still residual acid reflux, or maybe there's reflux but they're non-acidic, or maybe there's no reflux at all but the patient has a functional disorder. And this is where that comes into play. Again, this should be done on maximal PPI therapy. Early on, we mentioned that the guidelines recommend performing pH testing up front for patients with atypical symptoms. And usually you want to do these testing off of PPI because you're asking the question, does this patient truly have GERD or no? If the patient does have GERD, you don't want to suppress it with PPI. So again, you want to do this type of testing off of PPIs. This part can get a little bit tricky, so I highly recommend that if you're unsure, you can always refer the patient to your GI colleagues who can assess this in detail. So here's a summary of the takeaways from this video. Number one, the typical symptoms for GERD are heartburn or acid regurgitation. Patients who have these atypical symptoms such as chronic cough, globus, laryngeal irritation, a lot of those patients don't have GERD as the sole cause of their symptoms, so usually more workup is required. Number two, the treatment for GERD is multimodal, which can involve lifestyle modifications, medication therapy, and anti-reflux procedures. Number three, if you're not sure whether or not a patient has GERD, the guidelines will recommend performing objective pH testing off of PPIs up front before initiating treatment. Number four, if you know a patient has GERD, but you want to know whether or not the acid suppression is working, then you want to perform objective pH impedance transnasally on maximum PPI therapy to see if they have residual acid reflux, non-acid reflux, or no reflux at all. Thank you for your time, and if you have any questions, I highly encourage you to reach out to your GI colleagues. Please like and subscribe.